Everybody, and welcome to our webinar today. I am Roy Schwartz. I am the Director of Marketing and Biz Development at Vishnick McGovern Milizio. To those of you who don't know, Vishnick McGovern Milizio, or VMM, is a full-service law firm. We provide comprehensive tailored legal services for all your personal and business needs. We have 3 offices, one in Midtown Manhattan, one in Lake Success, Long Island, and one in Oakhurst, New Jersey. You are welcome to visit us at vmmlegal.com. And I would like to introduce today our speaker, Dr. Evan Schwarzwald. He will be talking about Heart Health 2021, what everyone should know. A little bit about Dr. Schwarzwald. Schwarzwald, board certified in cardiovascular disease, nuclear cardiology, and internal medicine. Evan Schwarzwald, DO, FACC, is devoted to providing comprehensive care to his patients. Dr. Schwarzwald, is passionate about educating and empowering patients and their families to live a healthy lifestyle. He's dedicated to working closely with his patients to understand their specific needs and to provide comprehensive cardiovascular care. His clinical interest is in preventative cardiology and diagnosis of cardiovascular disease. Without further ado, welcome, Dr. Schwarzwald, and thank you for being with us.
Right, great. So I'm just going to probably just tee you off here and thank you for everybody for attending. And I know those of you who are attending after I finish, welcome also. I'm going to share screen here, I guess. It's the next move. So I'm going to share my screen, and then we're going to, I think you have to enable me to share. Just let me know. There we go. All right, let's get the slide deck up. Can you see that?
Not yet. We can see you.
And can you see my slide deck now?
No, you sometimes have to click the actual slide and make sure.
That's host disabled. I need screen sharing enabled, I guess.
The screen share is not enabled.
Apologies.
Give me 1 second. We'll fix that right away.
The trials and tribulations of digital meetings.
Second, yeah, exactly. We live in a brave new world. Share screen. Okay, you should be good. Try now.
Okay, there we go. All right, share. Okay, you should see me now.
Mm-hmm.
Okay, let's get that queued up. All right. Okay, so what everyone should know in Heart Health 2021, I'm a clinical cardiologist, so I'm not somebody who just gives lectures all day long. In fact, I see probably over 100 patients a week in my office in Lake Success. And, you know, cardiology, the reason why I went into it is because, number one, I had family members who were affected by this disease, which I saw quite a bit of suffering from this disease. So I think it motivated me when I was a young man to go to school, go to med school, and try to conquer this disease. The other reason, after I went to med school, I found that I was still interested in it, because many times your interests change as you go through the residency training program, is that I saw that we could do a lot for people. We could sometimes even resurrect the dead, which I thought was absolutely fascinating. When I was a chief resident over at LAJ, Long Island Jewish Medical Center, I used to attend every cardiac arrest, and I found that there were a lot of deficiencies in the way we were resuscitating people, and started to put together paradigms to help resuscitate those patients, and percentage went up dramatically by the end of the year. So it shows that being interested in making an effort really does help. And I think that's what most cardiologists that's the high that we get when we work. So without further ado, I'm going to jump into our slides. We've got a lot of slides to go through, so I'm going to move quickly. So the topics we're going to cover today is what's new in structural heart disease. For those of you who don't know what structural heart disease is, that's the inner chambers or workings of the mechanical parts of the heart. It's not the arteries, it's the actual muscles and valves. And we're doing a lot of things in that area right now. We're going to talk to you about what's changing in atrial fibrillation, which is a very common disease and most common cause of stroke in our country. We're also going to talk about what new tools we have for everyone to prevent having to deal with the first two topics, the first two lines there. And then we're also going to go through some pharmacology to understand what's happening on the drug front. Because most of us are going to be dealing with the new tools and the drugs, and hopefully we never have to deal with the interventional stuff. We never get sick enough for that. If we do our jobs in prevention, we won't need to go down and have structural heart disease see us. So let's talk about that. So the update on structural heart disease, we're going to talk about three main valves today: the aortic valve, the mitral valve, and the tricuspid valve. All three of these valves are right now actively being looked at by our structural heart disease team. And we have ongoing clinical trials to sort out what are the best techniques to fix valves. Obviously, we have open heart surgery. We can fix any one of these valves with an open heart right now. But the key thing for cardiologists is that we want to put the cardiothoracic surgeons out of business. Now, they're not that happy about that because they're our colleagues and we love them because they do save lives. But we do want to put them out of business. We don't want to have to cut people open. We don't want to have to put people on bypass machines. So we're trying to find techniques to get around that. So we're going to show you some of that exciting new work that's being done. So we're going to review the current state of SAVR versus TAVR. SAVR means surgical aortic valve replacement versus trans-aortic valve interventions, or TAVR replacements. We're going to use this current state of knowledge on mitral clip. We're not going to get into too much on mitral valve replacement, but it can be done, so I'll talk briefly about that, and then we'll review some of the work on the tricuspid valve. So let's start off with the aortic valve. What is a TAVR? Well, it means transfemoral aortic valve replacement. Normally, if I have to put an aortic valve in somebody, I have to send them to a cardiothoracic surgery. They have to spend about 4 hours on an operating room table. They have to have their chest cut open. This is a true open heart surgery where the heart has to be open. You know, a bypass, a coronary artery bypass, is not a true open heart because the heart is never opened. We're just sewing the blood vessels on the surface of the heart. We're putting in new blood vessels there because all the blood vessels run on the surface, but valves are on the interior of the heart. So it's a true open heart surgery. As you can imagine, it's very invasive and there's morbidity and mortality associated with these kinds of operations. One of the main reasons why someone would ever have an aortic valve replacement is for aortic stenosis. It is the most common reason to have an aortic valve replacement. And you can see what happens over time, that there's a latent period where the heart is increasingly being stressed by a narrowing aortic valve. And that's what stenosis means, because I'm going to be try to be very lay person, because I don't know the actual level of understanding here, but aortic stenosis means narrowing of the aortic valve. It happens through life. Some people are more prone to it. We don't actually understand why some people are more prone to it than others. Other people are born with a congenitally abnormal like a bicuspid aortic valve. Normally the aortic valve has 3 parts. This would be a 2-port valve that people are born with. And you don't necessarily know this unless you go to a doctor who actually listens well to your heart to detect a murmur, and then you get something called an echocardiogram, which is a sonogram of the heart to detect these structural abnormalities. Once this happens, you stay asymptomatic for a number of years. And then, especially in acquired aortic stenosis, which is just an age-related aortic stenosis, you can see here what happens, what can happen. This is progressive overload, and then there's a sudden decline. okay? And this is the percent survival, and you can see you're just coming right off a cliff, and you get chest pain, passing out, congestive heart failure, and you can see that once you have congestive heart failure, your average survival time is about 2 years. So this has a worse prognosis than most cancers these days, just to put it in perspective. So I wanted to show you what this actually looks like, because part of this is to understand, what we actually do. And I'm going to just play this quick video for you, and I'll describe it or animate it along the way. If let's see if it's going to work. That's always. There we go. Let's see. There we go. So this is one of the companies that make and engineered one of the first valves to be put in humans without having to cut the heart open. And what you see is a heart beating here. And we're going to take a bird's eye view on the aortic valve. And you can see that it's very calcified. It's very nubby, and it doesn't open well. So that heart is struggling because it's pumping against, instead of pumping against an orifice the size of a $50, it's pumping against an orifice the size of a dime. It's like breathing through a straw. It's not easy. So we go up to the heart from the leg with a platinum wire, which is very soft. And along this wire, it's got a catheter that can be slid along it. And we put a balloon across the aortic valve. And we expand that balloon and we rip open the valve. That's kind of crazy, but it works. The valve is now torn open, so there's a little more space. And the reason why we need that space is because now we're going to put in a second catheter. And you see we're coming up through the leg. So this is done without cutting the patient open. There's a small catheter put into the leg area. And along that catheter now, we have engineered a valve that is crimped on a balloon. And you can see it right there. And it's sitting right there. And that is now going to be opened up with a balloon. And the valve then springs like an umbrella. It's like opening an umbrella, okay? And then we take out the device, the catheter, and we pull out our wire. And lo and behold, we took that gnarly, calcified, very narrowed valve, and we replaced it with a valve that now opens normally, relieving the internal pressure on the muscle of the heart. This is fantastic technology. There's several different companies that make this, including Medtronic and a couple of other companies that are making valves, a Lotus valve, etc. And this technology is what we use every day now in patients with aortic valve disease. Now, how did we come to the conclusion that this was good? We just don't go ahead and ask for volunteers. Everything in medicine is done in a very particular and precise way, and we always use something called a randomized double-blind, if it could be blinded, or randomized controlled trial to see if our techniques are actually having an effect. And this is an article published in 2019 in the New England Journal of Medicine. They took 734 patients and they randomized them to either surgical valve replacement or this technique, which you just saw. And they looked at it after 24 months to see whether these techniques, if these techniques actually performed as well as surgery. All we were looking for is just to see if it performed as well as surgery. And you can see here on the right that this is the death distribution in percent over 2 years in these patients. These patients were not young, healthy people. It was first, these trials were put together for people who had no way out. They were 90 years old, very, very elderly, very, very sick, and they were otherwise going to die of their disease. And they were offered these surgeries versus this transfemoral approach, which is not a surgery, it's a procedure. And you can see here that the death rate for surgery, given the fact that these were very sick people, was higher than even the new technique. And thus, this was now looked at in a very serious way. And the modeling and the computer engineering that goes into putting that valve on that balloon is unbelievable. You know, it's been in development for many, many years. So at 30 days, the TAVR was compared to surgery. This is the stroke rate. It was 0.5 versus 1.7. Bleeding complications were less. Acute kidney injury was less. Atrial fibrillation was markedly less. Severe aortic regurgitation was slightly more, but not overwhelmingly more. And pacemaker implantation was more. So having less disabling stroke and having less AFib and less bleeding and less death, with a little bit more complications on the regurgitation side, with valve leaking a little bit because we're pushing the old valve to the side so that that valve is sitting in there, is going to leak a little bit around the sides, not in the middle of it. We had a little bit of that, and we also had to put pacemakers in because as we put that big balloon in the aorta, we were pressing on some of the conduction system. Now, this is the early data, and I can tell you now that we have like 4 or 5 new iterations and new engineered valves where they actually have some material in the caging that expands, almost like that foam that you would put in your house when you're trying to insulate your house and you spray it in and it expands. Well, we have this foam that goes in the cage and it kind of expands. So this regurgitation rate is now further down. It's much, much less. And pacemaker implantation is now much, much less because we have more precise techniques to model the heart. And we can even make 3D models of these, with these 3D printers. We can take the CAT scan information and actually make a 3D model of the patient's aorta to size up that valve perfectly. So we get a lot less as pacemaker implantation, but it still does happen. But if that's the price you have to pay in order to not have the operation, I still think it's a pretty good surgical procedure. There's also the hemodynamics, and this is the orifice, the size of the orifice. Right now, we can get the orifice with the replacement valve actually to be somewhat bigger than the surgical valve, because when the surgeon has to put it in, he has to get his fingers in there and sew it in. So many times he's going to take a valve that's actually a little bit smaller so that he can get his fingers in there and wedge it into the aorta as he takes the old valve out. So we actually have very good size comparison with surgical aortic valve replacement, which was the gold standard up until a year or two ago. The Partner 3 trial looked at all this, and then they took patients who were not as sick, so who weren't very, very elderly, and they started randomizing them to younger patients, people who were in pretty good shape, okay? And that was a pivotal trial with 500 patients in each arm. And they actually found that in the younger patients who weren't as sick, that the risk of stroke, death, and rehospitalization was much lower in the transfemoral approach, where we put it in through the leg. And this is one of my colleagues who was at the American College of Cardiology meetings in New Orleans in 2019 before the pandemic, when we all used to be able to travel to meetings and meet our colleagues. And his quote was, "We've now looked at a broad risk spectrum of patients, those with high, intermediate, and low surgical risk. And these series of trials have shown that TAVR is better than or as good as surgery in terms of disabling strokes and death from all cause." So thus, we're in a new world when it comes down to aortic valve replacement. And again, the iterations of this continue to come. The Partner 3 was one of the first trials, and they used that SAPIEN valve that I showed you in the animation. And here you have some of the other competitors that are coming out, and you can see now that they have the mesh in here, okay, to help close off some of the leaking that was associated with crushing the valve and pushing it up against the aorta as we expanded the new valve in that orifice. So there are procedural complications. We all know that. We've been working on these to make sure that we minimize these, but the big ones are obviously bleeding from the site of puncture. Stroke is always a possibility whenever you're doing a cardiac catheterization. We also can have the paravalvular leak, but we're handling that with these new iterations of these valves. Acute kidney injury, of course, when we're putting dye in to see where the positioning of the valve, or if there's cholesterol plaque that embolizes downstream into the kidneys. And of course, a pacemaker might be needed for heart block as we press on some of the conduction system that lays right in this little area here. your conduction wires will come down this side of the heart. So you can imagine this little hinge point here can hit the conduction system. So sometimes we need to have a pacemaker. Is a TAVR for everyone? Well, I don't know whether any of you guys recommend, I certainly recognize this gentleman. That's Mick Jagger from the Rolling Stones. In 2019, in March, he became short of breath. He was followed by a cardiologist who knew he had aortic stenosis, and he was giving a concert in March of 2019. And he went to see his cardiologist shortly after one of his performances, and his cardiologist said, Mick, that valve is done. You got to come in and you got to get fixed. So they canceled the tour in March of 2019. And the next show that Mick Jagger gave was in, I believe, Houston in September. I could tell you he was moving around as good as he was when he was 20 years old. So next time you see the Rolling Stones, you won't necessarily think about, Jumping Jack Flash or one of the other famous songs that the Stones have written over the years. But you might think about, wow, that's a guy with a artificial valve that was put in through his leg, and he never needed open heart surgery. So he had that done here in New York, by the way. Next topic is mitral valve disease. One of the things that has advanced cardiology is that we now have 3D imaging of the mitral valve. Don't forget, echocardiography is sound wave based, so it was always a 2D image. That's what we've had for the last 20 years. It's still the most popular way to image the heart. But when we detect things on our 2D echo, we can now get a 3D study, and we can do this with a transesophageal probe, which means we go into the throat like you have an endoscopy, and we can actually sit right behind the heart because the heart is sitting right here, okay? And we can see the valves, okay? Because there's very little space between the esophagus and the heart. And we can send sound waves in here and get excellent 3D images of the valve. And the valve has multiple components, and we can see each one of those components. So we invented something for leaky mitral valves to try and close down the leaking, because the leaking, when a valve leaks, when the mitral valve leaks, it produces something called ineffective circulation, which means blood goes out and then blood leaks back in. Blood goes out and some of it leaks back in. So you have an ineffective circulation, like a circle movement of some of that blood, which makes you short of breath. It makes you tired. It can make you fatigued. And people who have severe mitral regurgitation need to have this addressed. And up until now, this was an open heart surgery called a mitral valve repair or mitral valve replacement in some cases. So let's watch this video of how a mitral clip goes in on a leaking mitral valve. Right? What happened here? Okay, there we go.
The heart is one of the most important organs in the body, working relentlessly to enable the human cardiovascular system to function. The heart has 4 chambers, the upper right and left atria, and the lower left and right ventricles. In a healthy heart, blood flows in one direction through the heart's chambers. Delicate tissue-like structures called valves function to ensure unidirectional blood flow within. The heart has 4 such valves, which regulate direction of the blood flow. The mitral valve separates the left atrium from the left ventricle and is made up of 2 thin flexible flaps called leaflets. When freshly oxygenated blood from the lungs returns to the heart, it enters the heart through the left atrium. Left atrium relaxation causes the mitral valve to open, enabling blood to travel into the left ventricle. When the left ventricle contracts, the mitral valve closes to prevent backflow. In some people, the mitral valve doesn't close tightly, causing mitral valve regurgitation. When the heart beats during contraction, the blood from the left ventricle can flow back up to the left atrium. Mitral regurgitation, MR, can be subdivided into functional and degenerative subtypes. Degenerative MR, or primary, results from anatomical abnormalities of the valve itself. In most cases, the chordae connecting the mitral valve to the pupillary muscle rupture or elongate, causing leaflet prolapse.
This is mitral valve
The
prolapse.
progressive disease, which if left untreated, can initiate a series of events culminating in heart failure and death. Current guidelines recommend surgical mitral valve repair or replacement in severe MR patients. For MR patients for whom surgery is not an option, minimally invasive procedures are available. MitraClip is a unique, highly maneuverable transcatheter system for mitral valve repair. This procedure avoids cardiopulmonary bypass using minimally invasive venous approach and transseptal puncture to gain access to the left atrium. MitraClip's steerable guide catheter is introduced over a previously placed guide wire. The dilator is used to gradually advance the guide into the left atrium, and the dilator and guide wire removed. The clip delivery system is advanced into the left atrium, positioning the clip above the regurgitant jet and perpendicular to the mitral valve plane. Inside the left atrium, the clip arms are open to 180 degrees and positioned perpendicular to the line of coaptation before crossing into the left ventricle. The clip is advanced into the left ventricle below the valve leaflets and retracted to grasp the leaflets. MitraClip grippers are designed to drop firmly into the clip arms, securely capturing both leaflets. Once the arms are closed, they create a double orifice within the mitral valve. Prior to clip deployment, echocardiographic imaging is used to assess procedural efficiency and leaflet capture. Prior to deployment, the MitraClip can be released and repositioned for optimal MR reduction. Once achieved, the clip is released and the full system retracted. The MitraClip procedure is a minimally invasive, highly effective treatment option for select patients with severe MR.
Okay, so that's MitraClip. And in order to do that, it just didn't, it seems like on video, it's so animation is so easy to do. We had to also, starting back in 2016 and 2017, we started putting together trials because we had engineered this device, but we didn't know how it would work and whether it would work. And there were two trials that were published in the New England Journal of Medicine in 2018-2019 time period with the Mitra FR trial and the COAP trial. The Mitra FR trial was a European trial, and the COAP trial was an American trial. Interestingly enough, the Mitra FR trial did not show a significant improvement with MitraClip. It was a little bit of a surprise because we really thought that after we were doing this, that the technology was really going to be useful in patients. So it was a little bit upsetting. This trial consisted of 37 trials in France. They had severe MR with low pumping function. So these are pretty sick, symptomatic patients. Some of them went under repair surgically, or they actually had the percutaneous or the procedure repair. And then the other patients were just left on medication. And the goal was to see whether this would do any better than medicine. These were pretty sick patients. So the composite of death from any cause of unplanned hospitalization for heart failure in 12 months was the endpoint for looking at patients' data. The COAP trial was a different kind of trial. It was done in 78 sites in the United States and Canada. And here, the patients weren't as sick. They had moderate to severe mitral regurgitation. Their ejection fractions were in the same range as the other trial, but their medical therapy was also optimized before they were even put into the trial. They had to have at least one hospitalization for heart failure in the last 12 months, and some of their biomarkers had to be up. The baseline characteristics, the average age was 72 years old, and their ejection fraction or the pumping function number is 31%, which is abnormal. It's supposed to be 55 or better. And they all had severe mitral regurgitation by our quantitative echo methods. And their primary follow-up was heart failure and hospitalizations at 24 months. And what we saw with, the MitraClip is that it really didn't perform as well as it should have, and that it wasn't doing as good as it should have when we did the Mitra clip analysis based on medical therapy. But there was a slight mortality difference in the device group. All these patients had background medical therapy, and you know, in these Mitra clip studies, optimizing the medical therapy proved to be a pivotal linchpin. So in the COAP trial, which was done after the French trial, the European trial, we learned something, so we changed the way we handled the patients and modified their protocols, and then we were able to see this mortality difference. So, and you can see here, I know you're not used to reading 3D echoes, but this is the mitral valve before a mitral clip was put in. And here's that mitral clip right here, okay, on echocardiography. But we can see that mitral clip with this kind of detail, and its anatomic position in the heart is absolutely remarkable, given the fact that we're using sound waves to create these images. So 3D echo has really revolutionized our ability to both identify the areas. You can see the hole in this valve is right here, okay, where the valve does not touch when it's closing. So this hole is where the leak is. And this is, we can precisely put this mitral clip in right where that leak is with this technology without any surgery. It's absolutely amazing technology. And we can do this for tricuspid valves now. This is the new frontier in Northwell. We're, you know, a pivotal center because Northwell is a 38 hospital, 32 or 38. They keep on getting bigger every year. But it's over 30 hospitals in the tri-state area. We are the largest employer in the state of New York. We have 80,000 employees. And because of the size of Northwell, it's a tremendous place to do research. Because we have a database that's probably unparalleled in the country. There's probably, maybe Kaiser Permanente has a bigger database than us, but we have a database probably either as big or second biggest database in the United States. So we're involved with the trial now to do this, and this is now right at the cutting edge. This is not being done every day. This is trial only right now. But this is what the future is. Okay, so let's look at the future and see what's going to happen here with this technology. You can see this looks very similar to the mitral clip. It's a little bit different. We've had to re-engineer it because the tricuspid valve has a different shape to it. But this is an incredible new technology that we're starting to use now at Northwell. We have patients that have been implanted with this with our structural heart disease team. And you can see here how we just get that valve closed off and we leave the clip in, and that reduces the severe leaking of a tricuspid valve for those patients who have that problem. So this is just another look at it from another angle. And again, individual controls on these devices. You can imagine the engineering and the man hours that had to go into making these things. Just incredible technology. And the people who are using them are very skilled. You do have to be very skilled. It isn't, it's not a video game. So this is our trial here. So if you know anybody who has severe tricuspid regurgitation, you can make a referral here to the structural heart team. This is our structural heart team here. I work with all these people. I'm very privileged to work with them. Very talented group of people. But these are that's the trial for the tricuspid valve. So let's go on to atrial fibrillation. What's new and why it's important? Well, atrial fibrillation, if you don't know what that is, that's an irregular beating of the heart. It's caused by fluttering of the top chambers of the heart, where the top chambers are no longer contracting in sync with the ventricles, which is what you saw in those animations. You could see that the death rate in people, this is the yellow and green for both men and women who have atrial fibrillation. The percentage of people who die is much, much higher. So it confers a mortality negative mortality survival on those who have it versus people who have no atrial fibrillation. It also causes stroke, and stroke is a disabling event. If it doesn't kill you, it leaves you maimed. The strokes from AFib tend to be the worst strokes. They're more severe. Larger pieces of the brain are affected, and patients are often bedridden or disabled and lose the ability to speak, and need assistance for activities of daily living. So it's an absolute horror to have someone have a stroke from AFib, and cardiology is trying to wage an all-out war on this disease by increasing awareness. Even our friends at Apple and Fitbit have created these wearable devices, and I encourage people to have these devices on and use them because they can detect atrial fibrillation before you have a stroke. So if you have hypertension or you have risk factors for atrial fibrillation, you should consider wearing a wearable if you're over the age of 40. These are the symptoms of stroke: irregular heartbeat, AFib, heart palpitations, chest pain, shortness of breath, fatigue, and lightheadedness. These are the risk factors: age over 65, high blood pressure, diabetes, sleep apnea, heavy alcohol use, underlying other heart disease like valve disease, which I just showed you with the mitral valve, aortic valve, or tricuspid valve, prior heart attacks, smoking, obesity, a huge thing. I just read an article from one of our digital scale makers that they had published the data on, I think, 500,000 people who have a digital scale in their house in the United States, and the average weight gain during the COVID pandemic was 2.2 pounds per month. So just figure that out over the last 12 months, what that really means for us. We're going to be very sick population if we don't get control of the obesity issue in our country, and overactive thyroid. So what is the, what is the nature of this disease? And one of my colleagues did a presentation on this recently, so I kind of took some of that data. And basically, people who have AFib get a diagnosis, and then they have intermittent episodes of AFib, but eventually many of them become persistent or permanent AFibers. And that also confers a negative risk because those patients get congestive heart failure, okay? And this is just a schema of how this all works. You don't have to know this. This is just medical stuff. But it's congestive heart failure that ends up happening to these people, which also causes their quality of life to become diminished, even if they're identified and given protection through anticoagulation for stroke. And that's what that would be routine. So atrial fibrillation is not benign. It's better to be in normal sinus rhythm, particularly in patients with congestive heart failure. Our question and our role and our mission is, can we improve patients' lives and outcomes by restoring sinus rhythm? There needs to be effective and safe methodologies to do this, and is something called catheter ablation of AFib an answer, or should we be treating medically? So we have medicine always, and then we have procedures. And we always need to know whether our procedures are going to work. As I told you with the mitral valve study, that the first trial on the mitral clip was very disappointing. And then we started to figure out why our clip wasn't working. And then we fixed those issues, kind of like how NASA fixed the little helicopter that landed on Mars the other day that didn't work when it came out of the box. Yet the engineers were able to fix the software and get that piece of equipment working. We do the same thing. We did a negative trial is not a negative thing. It's actually a positive thing because it allows us to move on to the next step. So negative and positive trials are important because it teaches us. Okay, so do we use drug therapy, or should we be using catheter ablation? And believe me, this answer is not clear cut. Okay, this is a tough decision. We know with drug therapy that patients will go on many times to have persistent or permanent AFib, and their life expectancy as well as their quality of life is diminished greatly. The question is with catheter ablation, can we help that improve? Now, what is catheter ablation? Well, catheter ablation is creating an electrical insulator to block signals of atrial fibrillation. And one thing that we learned over the last 10 years is that AFib, 90% of AFib come at the junction of the left atrium, and this is a model of the left atrium in an actual patient, and that left atrium has 4 veins that drain blood from the lung, and the interface of the vein to the muscle. So it's kind of like when you're driving over the Tappan Zee Bridge, right? You're on the road surface with this asphalt, and then all of a sudden you get onto the bridge, and now you're on some grading, and it's not the same road surface that you were on. Well, the road surface changes here, and that interface between the road surface, okay, is where the electrical instability comes as patients get progressive fibrosis of the heart from long-standing hypertension, which is probably the #1 cause of this, atrial fibrillation. Long-standing hypertension causes morphologic changes here. And what we do is we want to block these areas because we know that these areas become electrically active and they start to hijack the heart, okay? So we can now go in with special catheters, and you can see them here, and we're able to create a series of burns to entrap the rogue arrhythmia and allow the natural, well-functioning part of the left atrium to take back over again. This is done in a beating heart, so you don't get to see the motion here, but this is actually an unbelievable thing that we have the technology to steer our catheters into this area and actually create pinpoint burns into this area to stop this arrhythmia while the heart is beating. It's an incredible computerized high-end technique to try and control AFib. Why go through all that effort? And here's again the same thing, just in a more of a cartoon setting where we take a catheter and we go up and we know where this is coming from. It's coming from these 4 veins, and we have to trap it in here. And we're doing this while the heart is beating. It's absolutely incredible that we can do this stuff. We have these special catheters now that help us make these burns so that they're precise and they're in exact place. Or we have these, we can make a burn using very, very cold liquid nitrogen kind of system where we make a very cold balloon and we trap it up into the vein there, and we can cause a circular burn. Either way, it traps the AFib, and that's something that we've learned over the years through the trials, and we know how to control this with this technique. So the ablation reduces the risk, reduces the AFib recurrence and the burden of AFib, and you can see how catheter ablation performs against drug therapy here in both of these slides. Ablation may prevent progression to more permanent forms of AFib, and that should have a dramatic impact on both the stroke rate as well as the heart failure rate and hospitalization rate. And how do we know that? Because of the EAST trial. This was a trial just published in August 29th of 2020. So you're talking less than a year ago. Why? Because we didn't have any really effective therapies, but now that we did, we said, okay, let's give this a shot against usual care. And usual care is drug therapy. And you can see on the blue line that the event rates are much lower with the catheter ablation. So we're now trying to move this into the mainstream. And this is the quick take from the New England Journal of Medicine on the EAST trial. Let's just play it so you'll understand how that trial was performed.
Patients with atrial fibrillation are known to be at increased risk of cardiovascular disease. Recent studies suggest that rhythm control of atrial fibrillation may reduce this risk. In an international multi-center randomized open trial, investigators compared the effect of early rhythm control with that of usual care on cardiovascular complications in patients with early atrial fibrillation. 2,789 patients with atrial fibrillation diagnosed within 12 months before enrollment were randomized to early rhythm control using antiarrhythmic drugs or AF ablation, or to usual care. Patients could be included if they were older than 75 years of age or had a prior transient ischemic attack or stroke, or if they met 2 of the following criteria: an age of more than 65 years, female sex, the presence of heart failure, hypertension, diabetes mellitus, severe coronary artery disease, chronic kidney disease, or left ventricular hypertrophy. The first primary outcome was a composite of death from cardiovascular causes, stroke, or hospitalization with worsening heart failure or acute coronary syndrome. Patients assigned to early rhythm control were less likely to have a composite cardiovascular outcome than patients assigned to usual care. The second primary outcome was the number of nights spent in the hospital. The mean number of nights did not differ significantly between the groups. The authors conclude that in patients with early atrial fibrillation, early rhythm control reduced cardiovascular complications, including stroke and cardiovascular death, without increasing the number of nights spent in the hospital. Full trial results are available at nejm.org.
So this was a pivotal trial because it's showing us that we can use this earlier in the game before people get so sick. So a new framework really needs to be developed. Atrial fibrillation is not benign. It's better to be in a normal rhythm if we can get you back into a normal rhythm. And many times we'll do what we call a cardioversion the first time you get AFib to put you back into sinus rhythm. But many of those patients will come back in AFib sometime down the line. And the question is, do you keep on shocking people all the time, or do you do a definitive therapy to try and restore sinus rhythm? We definitely can improve patients' lives and outcomes by restoring sinus rhythm, which is a normal rhythm of the heart. Symptoms, congestive heart failure, hospitalizations, and some patients, stroke and mortality can be reduced. Catheter ablation of atrial fibrillation is more effective than medical therapy to reduce all AFib recurrence, burden, progression, and persistent AFib. And obviously the technology and success and evidence supporting this measure is rapidly progressing. Don't forget, this was just published a few months ago. So, North Shore is, one of the leaders in this field. We have a very prestigious electrophysiology team headed up by Dr. Larry Epstein. And we have at Southside Dr. Chinitz. This is now progressing to the next level, and there's more studies being done. The risk factors, of course, it's a 4-pillar management. We want to manage hypertension. We want to anticoagulate these patients. We want to control the rate. But now there's a new pillar here about doing rhythm control. And alongside here is just some of the other things that are risk factors for AFib. Aggressive treatment of any of the reversible factors is very, very important. So if people have underlying obesity, diabetes, sleep apnea, all these things need to be treated because atrial fibrillation, again, causes significant morbidity and mortality. Northwell's creating a AF Center of Excellence, and our heart hospital at Manhasset is the leader in this area. And we have electrophysiology, top-notch electrophysiology, both at Lenox Hill in the city and Southside Hospital, in addition to Manhasset. So we really covered the tri-state area pretty well with top-notch surgeons, electrophysiologists, cardiologists, nutritionists, and weight management people. So let's talk about cardiac prevention, because those are diseases that are already the cat is out of the hat. We need to, now think about preventing it. So a couple of questions that come to mind, and I want to try and move quickly here because we're kind of running through time very quickly. What is it history and physical enough? What does blood work for cholesterol really mean? And what tools do we have to reduce cardiac risk and prevention? So let's just move through it. Here's the Harvard Health letter. Heart attack despite low cholesterol. Here's a question that was asked to the publisher. Someone who had a cholesterol level of 155 yet had a heart attack with a 90% blockage in one artery. Has that happen? So in a population, lower LDL levels on average are associated with low risk of heart attack, but half of all heart attacks occur in people with normal cholesterols. What that tells me is that it's not a great test. Some of the best known ones are smoking, diabetes, high blood pressure, obesity, and lack of physical activity, but other important contributors include secondhand smoke and air pollution. So those other things and genetics are likely a big risk factor. So the LDL level in and of itself, or the cholesterol level in and of itself, is actually not a good biomarker for risk stratifying patients. What happens if you can't take a statin to lower your LDL? Well, that's important too. There's tremendous risks, benefits for statin therapy, but there are some people, for whatever reason, cannot take a statin. The benefits clearly outweigh the risk, so we want to lower LDL. Statins do have side effects. They're rare. I don't find that we have a lot of them in our practice, but there is a lot on the internet about it. So it's almost a self-fulfilling prophecy that someone will say they have joint pain. Who gets treated with statins? People who are generally over the age of 40. Who has more joint pain? People who are over the age of 40. A lot of this is age related, but people want to, people try to attribute their not feeling all that well to the drug. It's because of the internet and Google and some of the misinformation that's commonly put out there. One thing we do know about statins is that it's a linear relationship between, this is a quarter of a century with hundreds of thousands of patients in trials. And if you do the regression model here, you can see it's a linear relationship. For any given level of cholesterol, I can lower your risk of heart attack. Just go down the line. And it goes all the way down here to levels that are below 60. So we have something called the PCKS9, and that's a medicine that we can use to reduce cholesterol.
High levels in the blood, low-density lipoprotein, or LDL cholesterol, can lead to atherosclerotic cardiovascular disease. As blood passes through the liver, LDL receptors on the surface of hepatocytes bind LDL. The resulting complex is internalized by the hepatocyte and delivered to the endosome, where it dissociates. The LDL particle is delivered to the lysosome and degraded, while the LDL receptor recycles back to the cell surface to bind more circulating LDL, further reducing plasma levels of LDL cholesterol. In this manner, LDL receptors play a key role in LDL homeostasis.
So you can see from this that these receptors that are on the surface of your liver cells play a key role in regulating your cholesterol levels. We now have new drugs called PCKS9s, and their brand name is Repatha and Praluent. And what these drugs do is they allow the receptor, and you can see it here. Normally it gets destroyed.
PCSK9 disrupts LDL receptor recycling, thereby reducing the liver's ability to remove LDL from the blood. PCSK9's critical role in the regulation of the LDL receptor makes it an important therapeutic target for LDL-C reduction. Leads to PCSK9 inhibiting circulating PCSK9 from binding to the LDL receptor.
Now this is PCKS9 here, and it binds the PCKS9, which normally causes the destruction of the LDL receptors. By having this monoclonal antibody, and this is a biotech drug, it's a monoclonal antibody and it's injectable twice a month. You take an injection and it actually puts this PCKS9 out of business. It knocks it out with a monoclonal antibody, and it allows the receptors to regenerate on the surface of the hepatocyte, which increases your clearance of LDL cholesterol. This is beyond statins. And in fact, if you're statin intolerant, you can actually still lower your cholesterol if you can't take a statin. But in combination with statins, it has been shown that this is a very powerful combination, and it reduces clinical events. And this was the original article here. You could see it can reduce your cholesterol levels by 63%, which is unheard of prior to this drug being invented a few years ago. And then also here are the death curves, and basically placebo versus the drug itself. And the drug obviously lowers the primary endpoints, which were major adverse cardiac events in both primary and secondary endpoint models. So in addition to statin therapy, you can reduce the risk of cardiovascular events by 15% with this medication. And that's heart attacks, strokes, and real serious diseases. So our armamentarium is starting to build. So that's on the LDL front. And those are the two, that drug, along with statins, we have great outcomes data to understand that those really help. What about triglycerides? Up until recently, doctors never even bothered you with triglycerides unless they were off the wall, like 500-600 levels. A normal level is about 150. So does it cause heart disease? Well, there's no question that very high levels cause problems, but now we know that most diabetics and people with a metabolic syndrome run levels between 250 and 500. And they were never really treated because we didn't have any medicines. There were several trials that lowered triglycerides with niacin and several other drugs. And those randomized trials failed to provide any improvement in overall outcomes. So this is the normal levels, less than 150, but we have a huge group of people, and this is mostly the people with pre-diabetes and diabetes that live in this zone. And this zone was found to have higher incidence of cardiovascular disease. So, you know, we need a new drug. And fish oil is a hot topic. Everyone loves fish oil. Everybody thinks it's the, you know, the best thing going. But the question is whether that was true or not. So here's all the trials, and you can look them all up if you want. The only trial here that had any trend towards positivity was the Jealous trial here in 2007. All these other trials on fish oil, both over-the-counter and prescription fish oil, did not improve cardiac outcomes. So there's absolutely no data. You have all your friends taking fish oil over the counter, they actually may be causing harm rather than doing anything good. It's been studied multiple times, multiple trials. It's pretty conclusive now. Over-the-counter fish oil doesn't do anything for you, okay? The only one that found any kind of benefit was this one here. And this one was a very special type of fish oil, and it wasn't a really big trial, but it had EPA in it and did not have the mixture of EPA and DHA, which is most fish oils. And then in 2019, the pivotal trial came out in a randomized controlled trial of that EPA only fish oil. And it was called the Reduce It Investigators, Reduce It IT. And you can see here that there was a 25% risk reduction in major adverse cardiac events compared to the placebo, which was mineral oil in capsules. And the number needed to treat to save one life was 21 people, and it had about 5,000 patients in it. So these were the overall stats. There was a 20% reduction in cardiovascular death, 31% reduction in MI, and 28% reduction in non-fatal and fatal stroke. And that drug is called Vascepa. It's a prescription only. It's very hard to get because the insurance companies do not want to pay for it. And there's an ongoing battle with cardiologists to try and get this drug for our patients. This is a recommendation from the American College of Cardiology, and it doesn't seem to have much of a impact on the insurers, but it is an indicated treatment for patients who have hypertriglyceridemia. And here's the indication here. What else is going on in cardiology? So those are, you know, the drugs that, you know, we use now. I will tell you that there is another drug that we can use that's oral in place of statins, but it has no outcomes data right now. So I didn't present it because we don't know whether it actually helps. Those trials are in progress, but if you cannot tolerate statin, there is an oral drug, but I tend to use drugs that have outcomes data until we know. I think it's a pure way of getting to the problem. But what is diagnostics in cardiology? Well, we have this calculator when you go to your doctor. Every doctor uses this. We plug in your numbers. It's basically pretty simple. It's age, weight, sex, smoking, non-smoking, and some cholesterol numbers. And it spits out a number of your risk, of what your risk is, your 10-year risk and your lifetime risk. The problem with this model is it doesn't unpeel your genetic risk. So we use, in my office, calcium scoring. And CT calcium scoring is a standard test to detect coronary artery calcification. We have seen it with histologic confirmation. It accurately quantifies the amount of calcification, which is associated with atherosclerosis and plaquing. And that quantification allows us to understand the plaque burden of an individual. It's not a marker of plaque vulnerability to rupture, but it is the more plaque you have, statistically, the more chance one of those plaques will rupture. And the usefulness is that it can tell us whether someone who has a strong family history but doesn't have a huge risk on that risk calculator, or they have other a secondary risks like inflammatory disease or connective tissue disease or chronic kidney disease, whether they're at higher risk. And if you have a calcium score over 300, your risk is 2% per year. That puts you in like a 25%, 1 in 4 chance of having a major cardiovascular event in 4 years. So these people need aggressive lifestyle modification and all the preventive measures we need to control this disease, because they do have heart disease. It just hasn't blown up on them yet. It's like a ticking time bomb. There are multiple scenarios where it's useful, but most useful when people have family histories and we're trying to decide whether they need statin therapy for their cholesterol, or we can continue to allow them to do diet and exercise, or whether they need to have some other surveillance measures like stress testing, et cetera, et cetera. So it helps. In many patients, it re-risk stratifies the patients even after they've gone through the standard risk calculator that we use when we have a physical with a patient. 2 things have to be considered, of course, and the person's age, sex, and ethnicity, and that we have normalization curves for all that. We consider abnormal anything above the 75th percentile for age, sex, and ethnicity, with an absolute score of 300 would put you in a higher risk category. So, and some people will say that any score over 100 needs attention, and I agree with that, actually. This is what it looks like. This is your arteries on CAT scan, and you can see these calcium deposits all through the artery here. And we get a score based on how much of this you have. The other thing is that when you have a high CAC score, you might want to go for an angiogram, right? Someone might talk you into that. You may end up in a hospital and they go, well, you have a high calcium score, go get an angiogram. Well, the problem with an angiogram, it doesn't, these coronary artery scores don't have a high diagnostic yield when we go to the cath lab. You can see that 62% of the patients who go to the cath lab for a high calcium score, only 62% do not have obstructive coronary disease. Only 37, 1/3 of those patients need a stent. 2/3 don't. So it's a good test. It helps us decide about statin therapy and whether we should be more aggressive. But if we have a failed stress test, okay, because the patient had a high calcium score, we have poor predictive power to understand whether that person really needs a cath or not. So what's the cutting edge? The cutting edge is CT coronary angiography. This is now coming of age. And what this does, and you can see it here, that it allows us to take the information we have from the calcium score and then apply it to see who has actually a disease that's worthy of going to the cath lab. And you can see the percentage of people getting an intervention is much, much higher, okay, compared to coronary artery calcium scores when we send the patient for these new types of CT coronary angiograms. See, almost half of those people need a stent or something else like that. There was this published data called the ischemia trial, and the ischemia trial did show that stenting, by the way, doesn't save your life. It's the medical therapy. And you can see that they randomized patients to 2 trials, 2 groups, those who've got intervention and those who are on medical therapy alone, and they found no difference in mortality. Now, why do stents get done at all? Well, because stents do improve quality of life, and and there's less overall sudden death with it, but you do need optimal medical therapy. So when you get your diagnostic test, it's the medical therapy that saves your life. Stenting is just a bridge to get you to good medical therapy, and that was what we found in the ischemia trial. So every day at work, I have to make these decisions. Which road do we take? The road of death or the road of life? It's not easy, because understanding what's going on in someone's arteries in their heart is a complex issue with multiple facets. But we do have these tools, and there are some changes going on, and there's a new sheriff in town, and I think this is going to be what we're going to be doing in the next 10 years. This is called CT coronary angiogram FFR. I know it's a long word, and basically what this is that this will allow us to risk stratify patients to find out who has an obstruction before we go to the cath lab, so that when you go to the cath lab, it's almost a guarantee you're going to get an intervention. And we don't have to do all those normal angiograms, which is wasting time and money and causing morbidity for people. So what this does is this is a non-invasive technique, and it's being compared to the invasive technique. This is an angiogram here, and during angiography, we knew that we could put a flow catheter down, and we can measure what we call fractional flow reserve. It's a tongue twister, and measure the flow before the narrowing of the artery and the flow after the narrowing of the artery. And we would be able to accurately tell who needs a stent. And we do this in a lot of cases in Northwell. We don't just put stents into everything, because stents don't save lives, okay? We want to know where a stent is going to be used the best. And it's going to be used the best when there's a very critical blockage. Subcritical blockages should not be stented. They can actually cause more harm than good. So what we did is we took the FFR technique, which is fractional flow reserve, and then we put it into a CT machine. And we took CT dye data, and a company out in California called HeartFlow, which is a branch of Stanford, okay, was able to tell the engineers, we asked the engineers if they could analyze the flow of the dye during a CT scan to see if there's a gradient of flow in order to come up with an idea or an analysis of what the flow is down a particular artery and whether it's critical, similar to what we did in the cath lab here. Mechanically, we do this by hand. This is done by CT, okay? And you can see this is what it would look like. Here's a flow of dye into a coronary artery by CT. What HeartFlow does is it takes the gradient of the dye and through very complex mathematical computation, builds a flow angiogram, not an angiogram of dye, but an angiogram of flow based on gradient of dye. And it comes up with a picture that looks like this. These pictures allow us to see two things. Number one, through heavily calcified arteries. So if you have a calcium score of 1,000, we can see through it. It allows us to see through it. And it allows us to see the flow characteristics of each blood vessel, okay? And that's the beauty of it. And you can see here that there's a narrowing, okay? And it's color-coded so that we can see where the flow is great and where the flow is worse, okay? And you can see here as these color codes change that this is gradient of flow, okay? And there are certain gradients, colors that we look for now because we know what that flow looks like this, okay? And this is a significant lesion that needs to have a stent. So in Northwell, we have that HeartFlow technique, and this is all the Northwell sites in the tri-state area, and it is now available at Manhasset in Great Neck at 611 Northern Boulevard. So we can get this test done for you. It does take time, and it isn't for everybody, so you do need to speak to your clinician. But those of you who may have very elevated calcium scores or other risk factors or have a positive stress test and are not prepared to go through angiography just yet, with permission of your clinician, may end up getting a CT coronary angiogram with a fractional flow reserve, or a CTCA FFR. I know it's a mouthful. So again, this is something that can help patients. And we see that those people who had fractional flow reserve guided therapy do better than people who are on medical therapy. And this was published in the New England Journal of Medicine just recently. And this is again showing you a color-coded area, and we know right here that there's a lesion, okay, and that this has to be fixed. And just some more pictures of similar type of imaging of coronary arteries, all by CT. So we're now becoming supermen. We're being asked questions by our patients. We're starting to get the technology to be really delivered. And CT angiography, according to some of our colleagues, and again, there's debate in cardiology about everything because nothing is simple, but a lot of us feel that the future is going to be with CT angiography to pick those patients who would best do well with stenting versus people who are getting stenting today for sometimes dubious reasons. And again, stents do not save lives. Cardiologists with good medical therapy save lives. So it's important to get a stent when you need it, and it's important not to get it, because if you get a stent when you don't need it, you're going to be on blood thinners for a long time, and it causes morbidity and mortality. Intracranial bleeding, GI bleeding, and a lot of morbidity is caused by inappropriate stent placement. And in North Shore, we try to be judicious and meticulous with our stent placements because we understand the data and we understand the literature. So with that, I'm going to wrap it up. I think I ran a little bit over 11 minutes. There was a lot to talk about, but I want to thank you all for sharing your time with me today.
Thank you, Dr. Schwarzwald. That was a lot to go through and kind of think. This has been recorded. We'll put it on our YouTube channel for you to revisit and share with other people this may be relevant to. I just put Dr. Schwarzwald's contact information on the chat, so you can click the link and it will lead you to his page and you can reach out to him with any questions. And again, thank you, Doctor.
I appreciate all your time, and you guys have a great day.
Bye-bye, everybody.